us. And then we've got, of course, Melissa Morgan, who's our wound care guru from Medline, and Greg Poteet with Medline. He's helping us with our supply ordering and getting everything set up for our wound care program. So Melissa, do you want to go ahead and get started, kind of introduce yourself and get started? And then I'm going to work on getting everybody else and make sure they are able to join.
Yeah, no problem. Thanks for hopping on, everyone. My name is Melissa Morgan. I am a registered nurse, board certified in wound care, and I work on our clinical support team here at Medline. So excited to be with you guys virtually. We're going to walk through your DIMES guidelines. We're going to talk about the different products that make up those guidelines. If you guys have questions at all throughout the way, please feel free to come off of mute, interrupt me. At any point in time, if you're more comfortable using the chat feature, that's totally fine as well. I might not just get to those until a little bit later on. So with that being said, I'm going to go ahead and start sharing my screen here. All right, guys. So we're going to hop in here. We're going to first start out with just talking about, what are the goals of healing, specific to wound care, of course, and why it's so important that we look at those goals each and every time we're doing an assessment with our patients. Then we're going to dive into what DIMES guidelines are, how to follow those guidelines, and then, of course, what products are encompassing in those guidelines. Then we'll do just a couple of different case scenarios, and they're not complex. This is just a way for me to make sure that I've explained it well enough. You guys are comfortable following these guidelines going forward, and it just helps tie it all together towards the end. And then lastly, we'll take a look at just a couple of the skincare products that encompass your guidelines as well. So wound healing goals. And again, please make sure that if you guys are not currently kind of thinking about your wound care goals when you're in there doing your assessments, that after today's presentation, you really start to think about these things and start setting realistic goals for the patient, for the wound, and also for yourselves as clinicians, right? Being realistic with how far we can get with wound healing. So when we look at goals for wound care, there's 3 different buckets. It's going to either be healable, it's going to be a maintenance goal, or non-healable goal. In the hospice setting, most of the time, we're going to be dealing in this non-healable wound category. But I want to talk a little bit about the other 2, because there are times where we have individuals on hospice services that actually do live quite longer than we expect. Or, they might have a minor type of wound that actually could be healable. So when we talk about a healable wound goal, we're determining here that the patient, the individual, can support the phases of wound healing during his or her expected lifetime. And really what that means is that all of the comorbidities are controlled. There's not medications interfering with that healing cascade. There's good compliance with the plan of care. If that is the case, then we are going to get as aggressive as we possibly can with our wound treatment. We're going to take all the tools out of our toolkit and we're going to throw it at that wound to try to get it to resurface. Maintenance, on the other hand, is where the individual might be able to support the phases of wound healing at some point during their expected lifetime, but at the current moment, something is occurring where they can't. So the example I like to give, and this might not resonate with you guys, but I do think it'll kind of put it into perspective, is let's say we had a patient who had cancer and they were undergoing chemotherapy. Obviously, with those cytotoxic drugs running through their system, they're not going to be able to support the phases of wound healing. Body's not concerned about the wounds. They're trying to treat the cancer. So that's where we might just get comprehensive with our care, because we're expecting, this individual to go into remission. So we get comprehensive with our wound treatment plan. We don't want the wound to deteriorate, but we're not going to get aggressive because we know we're not going to really make any leeway with this wound. And then non-healable. Again, this is probably where we're going to be working mostly with our hospice population. This is really about comfort care. So what comfort care consists of is we want to try to utilize dressings that will decrease odor. We want to try to utilize dressings that decrease pain. So a lot of that has to do with gentle dressings, dressings that have longer wear times, so we're not in the home or in with that patient on a, every other day basis, having to change that wound for that individual to endure that type of pain that comes with a wound dressing. And then of course, trying to keep that wound from becoming infected as well, because that could lead to a whole other slew of complications. So again, each and every time you're in there with that patient, we should be thinking, okay, what is my goal here? How is my treatment plan going to be driven based upon that? So when we look at the DIMES guidelines, some of you may be familiar or at least have heard this acronym before, and it follows basically the principles of wound healing. It's all evidence-based, it's all evidence-based driven, and it's looking at debridement, infection, moisture balance, edge/environment. This is really referring to a stalled wound, and we'll talk a little bit more about what that means and when do we determine a wound is stalled. And then S is for your supportive products, things such as compression and secondary dressings. So this here is a copy of your specific customized guidelines. So all of the products you see here on the screen are on your formulary, and of course are plugged into these different categories based upon the features and the benefits of the product itself. So I'm going to walk through how to follow this somewhat quickly, because again, we're going to follow this up or kind of in this meeting with a couple of case scenarios that again make this a lot easier, I think, for you guys to understand. But when we look at DIMES guidelines, we're always going to start up here. You're going to see 1 through 4. And we're really starting with 1 and 2. This is talking about cleansing our wound bed, right? We want to clean it like we mean it. Regardless of what our goal is, our cleansing method needs to be extensive, it needs to be thorough, and it needs to be appropriate, because we don't want these wounds becoming infected. Next, we're going to be applying our skin protective barrier. So we're protecting our peri-wound. We want to make sure that our peri-wound's protected from any sort of adhesives that we're putting down onto the skin, as well as protecting it from any sort of potential wound exudate it might come into contact with. So we're always doing those 2 things to start out every single wound dressing, every single wound assessment. Following that, you're then going to drop down into one of these 4 rows, and you're going to see these images here on the left-hand side with just a brief description right next to it. So this is asking you as the clinician, what are the characteristics of the wound you are assessing? Is it shallow and dry or just somewhat moist? Is it shallow and wet? Is it deep and dry, or is it deep and wet? So when we talk about shallow versus deep, if a wound is 2 centimeters or less in depth, you should probably consider that shallow. Anything over 2 centimeters in depth, we're going on that deeper side of the spectrum. As far as wound exudate, dry/moist, pretty self-explanatory. Wet, it's really those moderate, heavy, copious, draining wounds. Once you've chosen your wound bed characteristic, and you're going to notice I never once said what stage is this pressure injury or what is the etiology of this wound, because right now, as far as the topical dressing is concerned, we're treating the wound bed characteristics. When we flip these guidelines over, because this is a 1-page document when it's printed, that's when we get etiology specific, okay? So let's say, for example, we've decided that the wound you're assessing is shallow and wet. Then we know we're going to be staying right here in this column and working our way across between these different rows. First question we're always asking ourselves is, does this wound need to be debrided? And if you ever forget how to follow this, the instructions are right up here below each letter. So does the wound need to be debrided? Meaning, is there slough or eschar within the wound bed? If the answer is, you know what, yes, there is slough and eschar in this wound bed, you simply stop there, and the direction is to use your TheraHoney. Again, we're going to talk about each of these products in more detail. If your wound was not, showing signs and symptoms of slough and eschar, then you continue to work your way across. Okay, is it showing signs and symptoms of infection? So I want you guys to think about some of those signs and symptoms of infection. Peri-wound erythema, malodor, purulent drainage, increased complaints of pain, increased amounts of drainage that we've not seen before. Those are all signs of infection. If the answer was yes to any of those, then our direction is to use OptiCell AG, which is our silver-based gelling fiber. Now, I do want to say before I go any further that sometimes you need to work with debridement and infection together. Okay, sometimes it's a combination of topical products. And really the reason is because normally when we see slough and eschar in a wound bed, it's because the wound is stuck in that inflammatory phase. So we're having to address both at the same time, and both of those products you see there are compatible with one another. Those are the only two columns that you would work together in simultaneously, okay? Sometimes you work in them individually, sometimes you work with those two simultaneously. But when you start to advance to the moisture and the edge column, those stand alone, okay? We're not combining a bunch of different products at that point. So if your wound did not show any issues with slough and eschar, if it did not show any issues with infection, then you continue to work your way across until you find the answer. So the next question is moisture balance. So most likely, if you did not need to address debridement, if you did not need to address infection, then you're looking at healthy, viable tissue. And really the goal in those cases is to just keep it nice and moist. We don't want it too dry, we don't want it too wet. And so because this is a shallow wound, doesn't necessarily need anything to fill a depth, you would simply apply Optifoam Gentle EX, okay? I'm gonna stop there before we get to the edge column. And I just wanna point out a couple of different things on these guidelines. When we talk about these products, you see, change Q7 days in PRN. That is not us at Medline telling you, hey, if you use honey or if you use OptiCell, you only have to change it once a week. That is just the max wear time approved by the FDA for these specific dressings. You are going to base your dressing change frequency off of your assessment as a clinician. So a lot of the times we're taking into consideration the amount of drainage that is coming from these wounds. So if you slide on over here to the very right-hand side under supportive products, you're going to see this first bullet point. Dressings should be changed if 75% strike through is observed. And so what that means is if you had a 4x4 foam, actually, let me grab one here that we have. So if this was my secondary dressing, okay, and I walked into the patient's home and I noticed that there was visible exudate on the outside of my dressing that reached almost all four corners of this, that's 75% strike through. So for example, if I went in on a Monday and I thought, yeah, I can get by with, Q5 dressing changes, Q7 day dressing changes, and I place this dressing on a Monday and I go back Wednesday for some reason and the dressing is totally saturated, that tells me as a clinician, okay, we need to increase the amount or the frequency of these dressing changes that we're doing. So lastly, I said I was going to pause before we got to that edge column. And the reason I wanted to pause is because we're only going to work in this edge column if you have determined that a wound is healable, okay? We do not work in this edge column if it's a maintenance or a non-healable wound goal. This edge column is where we're getting pretty aggressive with our wound care. And when you do work in this edge column, if you've determined, okay, my wound is healable, when do I progress past moisture balance? When do I progress into this edge column? It's when you've been doing everything correctly as far as treatment is concerned for the last 2 weeks. You've been working in that moisture balance column. You've been dealing with healthy, viable tissue. You've addressed debridement. You've addressed infection. You've just been trying to maintain that perfect level of moisture. But over the last 2 weeks, every single time you go in to see that patient, the wound does not change. It doesn't get worse, but it's also not getting better. That is a stalled wound. And there's oftentimes a couple of underlying issues that make a wound stalled. One of them is biofilm, and the other issue is collagen, so it's either lack of collagen production or it's excess MMPs. If you guys are not familiar with what MMPs are a natural enzyme needed for wound healing, but when they start to develop in excess, they actually start to eat off of the body's own collagen. And collagen is needed for the last two phases of wound healing. So you see Puricol Plus in this column here, this edge column on your guidelines, because Puricol Plus is 100% native-based collagen dressing that addresses those issues. And we'll talk about how and why when we get to that product specifically. Now, at the very end, that S column, again, this is your supportive products. And you're going to see that we have your secondary dressings that address dry wounds, wet wounds, copious amounts of drainage, your heel wounds, and your sacral wounds. And we'll talk about each of those individually as we walk through the products. Now, we know that that topical piece of treatment is only one piece of the pie, right? Now, this is on the backside where we get very specific to wound etiology. So we know that, yes, we can treat the wound from a topical perspective, but we need to look at other interventions to actually resolve or at least help this wound progress through that wound healing trajectory. So these are intervention suggestions for you guys based on etiology. You can see up here, you have your pressure injuries. So what are some other things that we need to take into consideration when we're treating a pressure injury? Are they on a specialty support surface, so a specialty mattress? Are they getting turning and repositioning on a frequent and scheduled intervals? Are we offloading their heels? Are we providing nutritional support? Then you can see we get into all of these other different etiologies, again, with those other secondary interventions listed for you guys. So venous ulcers, you know, we talk about compression therapy, we talk about, again, nutritional support, pain management, but these are all things that you guys need to be considering outside of just your topical treatment in terms of what do we need to do to help this patient? What do we need to implement into this plan of care? So it goes venous surgical down here on the left-hand side, but when you come up here to the right-hand side, you're going to see we basically have really, I would say, more of your very, very common skin alterations that you guys are probably dealing with on a daily basis. So skin tears, incontinence-associated dermatitis, your fungal rashes, intertriginous dermatitis, intact compromised skin. These are all things that we come into contact with as clinicians on a pretty consistent basis. So we want you guys to understand and know, you know, what is the best product on our formulary to treat these skin issues. Down here at the bottom, these product images, if you are utilizing the PDF version of the guidelines, which we can distribute to you in PDF form, you can actually click on these product images and it takes you directly to an instruction for use video. So if you haven't used the product in the past, or you've forgotten how to use it, or you just want a little refresher, simply click on those images. It takes you directly to medline.com. You're gonna have everything you need to know about those products. Last but not least, this number over here in the blue box, this 888 number, this is a number to our skin health hotline. This is available to you guys Monday through Friday from 9 to 6 Eastern. So just keep in mind the time change or time zone differences, really. And this is managed by a fellow colleague of mine. Her name is Gail. And this is a resource for you if you have a question about a product, if you have a question about a wound, maybe you feel like, hey, you know, I've been following these DIMES guidelines. I feel like I've been doing everything correctly and I'm just not sure where to go from here. The wound's not progressing. It's not doing anything. Call this number and we can help troubleshoot with you. Now, we can't give you orders. We're not prescribing clinicians, but we can normally get you to where you need to be to make a recommendation to the provider or, you know, make a decision going forward in terms of your treatment plan. Any questions before I start getting into the products themselves? Okay, I can come back if there is, but let's continue to work through here. Now, as I walk through these products, I'm not going to read to you guys line by line the slide deck here. Okay, I really want to talk to you guys about, you know, when would you consider using this, or what are just some clinical pearls that you need to walk away with? We can get you guys a copy of this slide deck as well, so you can kind of read bullet point. It's really talking about indications, contraindications. But as I walk through it, you guys can look at the slide and then just listen to what I have to say about the product itself. So the first one is your Skintegrity Wound Cleanser. Now, we mentioned earlier that we're always going to do wound cleansing, and our goal is to clean it like we mean it. Now, the reason that we recommend using a wound cleanser versus normal saline, and I asked the group earlier today that I was in person with here, how many of you guys are using normal saline to cleanse wounds? Luckily, none of them were. They were all using a wound cleanser, and that's great. And here's the difference. If you guys are using normal saline is not cytotoxic to the wound, meaning it's not going to damage healthy tissue, but it's also not very effective in terms of actually cleansing the wound. And here's what I like to compare it to. Cleansing a wound with normal saline is like getting into the shower in the morning and all you do is let the water run over you and you step out. You don't grab shampoo, you don't grab conditioner, you don't grab body wash. You just let the water run over you and that's it. You might feel a little bit cleaner when you get out, but you didn't get the dirt and grime off of you. Using a wound cleanser is like getting in the shower and grabbing your loofah, grabbing your washcloth, grabbing your body wash, grabbing your soap, and truly scrubbing yourself clean. And that's what we need to do for our wounds because we want to make sure that these are not becoming infected. Not only do you want to cleanse your wound bed itself, but we always want to make sure that we're cleansing our peri-wound, the surrounding tissue of the wound, because it's a really nice harboring ground for microorganisms that could eventually migrate into the wound bed itself. So clean it like you mean it. If you're using this larger spray bottle, we have an 8 ounce, we have a 16 ounce. You want to make sure that you're holding the tip of the spray bottle about 3 inches away from the wound bed. And that's going to deliver the appropriate amount of PSI of about 8.6 that has been proven to be effective for wound cleansing. If you're using this smaller size, this does not have a measured PSI to it, but I still do recommend holding the tip of it about 3 inches away from your wound bed. So we've cleaned it like we've meaned it. Now we're going to protect our peri-wound. So you always want to make sure that you're putting down your barrier film or your Sure Prep on your peri-wound. Again, in areas that are going to come into contact with adhesives and in areas that have the potential to come into contact with wound exudate. Keeping our peri-wound healthy is extremely, extremely important. Because once that wound actually, granulates or epithelializes up to the surface of the skin, those epithelial cells that are the peri-wound have to be healthy enough to actually start to migrate and close that wound. So peri-wound protection, peri-wound health, extremely important, not a step that we want to miss. So utilize your barrier film with each and every dressing change. If you're using the rapid dry, it's a 30-second dry time. If you're using the no sting formulation, which I believe is the one that you have on your formulary, that's about a 60-second dry time. Comes in a spray, comes in like an alcohol swab, comes in what I like to call these little lollipops here. All do the same thing. They're just, different techniques in terms of applying it. Now, Marathon and Marathon XL, this is what I like to call Sure Prep on steroids, but it actually functions a lot differently than your standard barrier film. And this is not going to be your go-to run-of-the-mill peri-wound protection. Marathon has its place. We're going to talk about when you might want to consider using it, but I first want to talk about what makes it unique, what makes it different than a standard barrier film. So when we look at your Sure Preps, your barrier films, those just lie on top of the skin, okay? It creates a film between the skin and adhesive. Marathon, on the other hand, actually binds with the skin itself. It's 100% cyanoacrylate. So I kind of want you guys to think medical grade super glue, basically. And you would want to consider utilizing it on peri-wound areas that are extremely denuded, ostomy sites that are extremely denuded, perineal area that's extremely denuded. And in these cases, when I talk about the extreme denudation, it's basically where your barrier creams, your standard skin protectants, your dressings won't stick because these areas are just so damaged. And I'm sure you can all relate to having a patient like this, right? To seal all wetness or all of that denudation to it. And a lot of that's been resolved while you're still a chief nurse, you know, making sure that's what I'm wanting to hear. Marathon also good. You might be trying to protect.
Hey guys, they're working on logging back in. Hopefully you can hear me okay. There's Greg. We're just waiting for Melissa to get back in. There she is. Okay, I see it in here now, Melissa. Hopefully this will work. Okay, I cannot hear you, Melissa, if you're talking. Start. No. Guys, for the technical issues here. I don't know why this is not working.
I'm gonna have to value this presentation real quick.
Okay.
Greg, yours is working.
Hello, everybody. Sorry for the delay, if you can hear me.
Yeah, I think we can. I can hear you, Greg.
Well, I have everyone, did everyone, if you could respond from Flagstaff and Globe, did you receive my little box I sent this week? You should have got it yesterday.
I think you said you guys got your box.
And if you
get
did
your-
receive the box, I actually put guidelines within the box, but they're inside the black brochure if you haven't looked already, if you don't see them. So if you're wanting your own copy of the guidelines, I actually sent some copies and they're inside the black advanced wound care brochure to make sure they would stay in good shape in the shipping from FedEx, just in case.
Chris, did you get your box?
I guess my volume is down. Now I'm back.
Okay, no, I heard you. Okay.
Oh, good.
And Chris has got her,
Yeah, she's
self-mute.
able to load in, but it wasn't allowing her to upload. It wasn't allowing her to connect completely. So
Okay,
we're gonna, and I'm already connected. So if you hear me fine, she's emailing me her presentation and she's gonna take over my computer.
okay.
I'm backup tech support Medline here at Thema in Phoenix.
You.
So when you texted me, was it just breaking up? What was it doing?
It was just breaking up. It was just getting, robotic is basically, right? So it's just, that it wasn't a good connection.
I hope mine doesn't do the same thing.
Your side was looking fine, but for some reason.
So far, so
that
good.
Other one wasn't.
Maybe I should keep talking while we wait.
Yeah, do you want to talk? We'll let it pop up here. Here is Melissa. Take two.
Okay, I see Chris. Chris is coming back in. Here we go.
All right, guys, so I'm waiting for my slide deck to, yeah, to reach Greg, but I want to be respectful of your time, so we can revisit the slides, but let me just start kind of talking you guys through some of the products. Kind of going back to Marathon, right? I mentioned that it's going to bind with the skin, so I think where I left off is that you're going to start to see it shed with the skin as our epithelial cells regenerate. So again, guys, not your go-to run-of-the-mill skin prep. There's a time and there's a place for it. Want to be, cognizant of the cost that's associated with that. But again, if there's an instance where you run into a very damaged area and you need that area protected because nothing else is working, Marathon's going to be your go-to for that. I think my presentation sent, so let me try to get that back up here.
You say okay?
I don't want to like look through your email, but
They're fine. It should pop. It should be the first one.
yeah, see, it shows sent. There
There
we
it is.
go.
Da, 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 da.
Okay.
Yep, I see it.
You see it? Perfect. All right, we're
Yeah.
back in business. Hopefully, it stays this way. Let me just start it as a slideshow. All right, so now when we get into debridement, we're looking at the removal of that non-viable tissue, right? So slough and or eschar, that's tissue that needs to be debrided from the wound. It's not going to go anywhere if the wound is not going to go anywhere if we continue to allow that to develop and grow within the wound. So you guys have TheraHoney on formulary, which is our 100% medical grade Manuka honey. You might be familiar with utilizing other types of Manuka honeys in the past, but this is basically a product that aids in autolytic debridement. So what I mean by that is the dressing itself uses the patient's own body to start to debride this wound. So specifically with honey, the high concentration of sugar in this dressing starts to draw in water from the body's surrounding cells, and between the honey and the water from those surrounding cells, it starts to liquefy that necrotic tissue. And that's how that debridement process works. So with any sort of autolytic debridement process, it's a slower process, right? But it's cost effective, it's less painful for the patient, and in most cases, very, very, very appropriate for patients, especially in the hospice setting. So you have both the gel and then we have a ribbon and a sheet. So the gel, the ribbon, and the sheet, they all do the same thing in terms of how they debride, all have the up to a 7-day wear time, same indications, same contraindications. What I like the rope for, or the ribbon, is obviously for packing undermined or tunneled areas that need debridement. And then when would you use the sheet versus the gel? And this is really going to be up to your discretion as a clinician. Personally, when I was still at the bedside, I preferred my TheraHoney sheet for my more shallow wounds. And then I utilized the gel for my deeper wounds, because if I'm squirting a bunch of gel into a shallow wound bed, sometimes it starts to seep over onto the edges and it just makes for a mess. It's not going to damage the healthy skin, but it just makes things pretty messy. So if you're trying to get it into a deep wound, you could take 4x4 and fluff it up and put your TheraHoney gel on that and then into your actual wound bed. Nice thing about TheraHoney, which is not common in all debridement agents, is that you can use it in conjunction with antimicrobial dressings. So your AG products, which is really important because you may have remembered me mentioning just a little while ago that you oftentimes do have to work in that debridement and infection column together. Now, as we look to infection specifically, again, think about those signs and symptoms of infection that we talked about. If you notice any of those, you guys have OptiCell AG. Okay, this is an antibacterial chitosan-based gelling fiber. What's nice about OptiCell AG and your standard OptiCell, which we'll talk about here in a minute, is that it can be used in both dry wounds and it can be used in wet wounds. So when you take OptiCell out of the packaging, it's dry. If you're using it to treat a wet wound, you simply place the product into the wound bed the way it comes out of the package, okay? The drainage is going to absorb into the OptiCell and gel it. Now, if it's a dry wound, we know that we need to don moisture to the wound bed, right? So you would take your OptiCell out of the package, you can moisten it before you put it into the wound bed or once it's been put into the wound bed, but you would moisten it with either normal saline or wound cleanser, okay, to don moisture, again, for your dry wounds. So what is chitosan? Chitosan is actually derived from the shellfish, the shell of shellfish. So with that being said, if your patient has any sort of allergy to shellfish, you might want to be a little bit cognizant of using this on them. Doesn't mean it's contraindicated because it's derived from the crushed piece of the shellfish, but you want to be cognizant of that. And then, of course, with any sort of AG product, we need to be mindful of whether or not the patient has an allergy to silver. Chitosan is really unique in the fact that it also has hemostatic capabilities. So if you had a wound with minor bleeding or oozing of blood, OptiCell AG or your standard OptiCell without the AG is going to help control that. So really unique feature. This also comes in a rope. So again, if you needed to reach undermined tunneled areas, you could utilize the rope form of this. Now, moisture balance. Again, this is where we're saying, hey, my tissue is viable. I'm just making sure that it's not too dry and it's not too wet. The first product you're going to see again is OptiCell. Just does not have the silver part because we're not worried about infection here. Same indications, right? We need to be concerned about that shellfish allergy. We don't have to be concerned about silver allergy with this because there's not silver in this specific product. Helps control minor bleeding. Can be used in a wet wound. Just stick it in there the way it comes out of the package. If we're trying to don moisture to a dry wound, simply moisten the OptiCell and place it within your wound bed. Also comes in a rope and then several, again, different square sizes. Now we get into your secondary dressings, okay? When you look at those guidelines, you'll notice again that we have, okay, for dry wounds, use this secondary dressing. For heavily draining wounds, use this secondary dressing. So Gentac is going to be for your dry to very lightly draining wounds, okay? This is a silicone island dressing. It has up to a 7-day wear time. It has a water resistant backing, okay? So water will repel off of it. It's not going to be waterproof like the Optifoams that we're going to go over here in a minute. Comes in multiple different square sizes. Really good for skin tears. If you guys are going to be, you know, treating skin tears, we know that steri strips and Tegaderms, those are not, you know, treatment regimens that are supported by the International Skin Tear Advisory Panel, known as ISTAP. Really, the recommendation is to reapproximate the flap if there's one present, and keep that area covered and protected, and allow that to resolve on its own. Now, when we get into your Optifoams, these are 5-layer foams, okay? 5-layer silicone bordered and silicone faced foam. These are going to be used for your moderate to heavily draining wounds. As I mentioned, this one does have a waterproof backing. I mentioned that because oftentimes, you know, once we leave the patient, we leave their home, and let's say, you know, the dressing becomes soiled with some sort of fecal matter or incontinence, whatever it might be. Family is really quick to think, oh my God, the whole wound is messed up. The whole wound is dirty. I have to change everything. And they take everything we've done and they remove it and they replace it. And we're disturbing that wound bed. And we don't need to replace an entire wound dressing if just the secondary dressing is soiled. If the wound has not become contaminated, we can simply take a wet washcloth or a wipe and wipe it clean. Because every single time we expose these wounds to the ambient air, meaning that we're doing a dressing change, we are taking 4 hours off of the wound healing process. That's how long it takes for that wound to get back to to healing temperatures, okay? And this is why daily dressing changes, BID dressing changes, those are no longer evidence-based. So the longer that we can keep a dressing intact and in place, the better. So just something to make sure you're educating patients and families about, because again, they're very quick to want to change everything out if they notice just a little speck of something on these secondary dressings. Now, when I talk about that silicone border, I'm sure you guys are all familiar with what silicone borders look like, feel like, but this also has a silicone face. And what that means is that the foam pad to our Optifoam is also silicone face. So when you feel it, you'll feel some stickiness. And sometimes nurses become somewhat alarmed by that feature. They think that that stickiness is going to adhere to the wound bed. And it's actually the opposite. It was actually designed because that silicone face is hydrophobic, meaning that it fears water. So when wound drainage comes into contact with the foam piece itself is going to absorb it. The silicone is like, oh, no, stay away from me. And that is why you're not going to see that our foam piece adheres to your healthy wound bed tissue. And that's really important because we don't want to disrupt that healthy tissue. So just don't be alarmed when you feel that and you're like, oh my gosh, why is this sticky? Because once it's in the wound, once it's absorbing drainage, it's not going to adhere to the actual tissue itself. So multiple different sizes in those squares. And then we have our sacral dressing, of course. This comes in a 7x7 and a 9x9. Does anybody want to come off of mute and tell me what the biggest challenge is with a sacral dressing or a sacral wound? Or put it in the chat box. Yeah.
Okay, my audio is open. I just realized, you know, okay, it's been a while since I've done wound care, but always it's the bandage rolling or the
Yes, perfect.
rolling back.
That is one of our biggest issues. It's either the dressing is rolling or the wound is becoming contaminated with urine and feces, because 99.9% of the time, these patients with sacral wounds are also incontinent, right? So we find that these dressings aren't lasting as long. And we're in there changing them. The wound is becoming contaminated. And these dressings, any sacral dressing, they have a hard job, right? Hard job to treat those sacral wounds. So there's something that I want to recommend to you guys right now. It is called our flower pedaling technique. And so you take your Optifoam and then you take pink tape, and I have a shot of it right here on the screen. This is our zinc oxide based tape. So it is also waterproof. It is very gentle on the skin because, of course, you know, the piece that's up against the skin is zinc oxide based. And this comes in multiple different sizes. The size I recommend for this technique I'm about to share with you is this 1.5 inch size over here in the corner. And these are all 5-yard rolls. So it's gonna 1 yard or 1 roll is gonna last you quite some time. So what you do is you take your sacral dressing, okay, and you're going to apply it just like you normally would in images 1 through 3 here. And then you're going to take your first piece of pink tape and you're going to place it right down here, nice firmly in that gluteal cleft. Okay. You're going to notice here that 50% of the tape is on the silicone border and the other 50% of the tape is on the skin. Then you're going to take your other pieces of pink tape, and you should have torn these off prior to starting. Sorry, I didn't mention that. You would take anywhere from 1/2 inch to 3/4 inch pieces, and you can tear this tape by hand, which is really nice, and get those ready to go. I want you guys to pay attention to the image on the very far right-hand side. This is what you're going to do with the rest of those pieces of pink tape. You're going to line the entire distal edge with this pink tape, and you're going to overlap each piece on top of one another by 50%. So this does a couple of different things. Number one, it kind of creates a roadblock for the urinary and fecal matter to get up underneath this dressing. And this is also going to keep those edges in place, because in addition to these individuals being incontinent, they're also most of the time bedbound. So as we reposition them, as we pull them up in bed, it's starting to roll the edges of that dressing. So this is really going to solve, or at least help solve, for some of those issues that you guys are coming into contact with when it comes to sacral wounds. I know that it's one more step, but a couple of minutes extra of your time is going to go a really long way in driving better patient outcomes, saving your time as a clinician, and then also reducing wasted product. So just something to keep in mind as you move forward with your treatments of sacral wounds. Now for your heel dressings, you have Optifoam Heel. This is a non-adhesive dressing. It's sort of like a cup that goes onto the heel itself. You can secure it with tape. You can secure it with rolled gauze. You do need to try to secure it just because because it's a cup, it's not really just going to stay in place unless that patient's completely immobile. If they're moving at all, or if we're moving them up in bed, it is going to move. So just make sure you're securing it. Again, can be used to moderate to heavily draining partial and full thickness wounds. And then OptiLock is your super absorbent dressing. Okay, this is for those wounds where you may have been using a foam and you're like, gosh, you know, I'm still in here every other day changing this dressing. There's just so much drainage. You might want to consider utilizing OptiLock instead. So OptiLock comes in multiple different sizes. It doesn't come in different shapes, but it does come in different sizes. A couple of things about OptiLock that you do need to keep in mind. There's a blue side and there's a white side. Always remember, blue to the sky, white to the wound. Okay, if you do it the other way, it's not going to absorb. What's inside of this dressing that makes it so absorbent are super absorbent polymers. I point that out because you don't want to cut this dressing. If you cut the dressing, it compromises the integrity of it completely. One other thing you need to keep in mind is that there's non-adhesive border to this. So if you're using it on a venous ulcer under compression, the compression will hold it into place. Other than that, you can use tape, medical tape around the edges. If you were going to use it, let's say on the arm for some reason, you could wrap that with gauze, but you do need something to help secure this or keep it in place. Now, getting to that edge and environment, again, this is for your stalled wounds. Please remember, we are only going to make our way over to this column if we've determined our wound is healable and we've determined that it's stalled. If you have determined those two things, then you're going to utilize Puricol Plus. So this is our 100% native-based collagen dressing. Because it's 100% native-based collagen, it is biodegradable. And I like to point that out because sometimes you might place this in the wound bed on a Monday and you go back Friday and the Puricol is not in the wound bed anymore, and you're thinking, oh my gosh, did I forget to put it in? Did somebody take it out? Most likely, no. Most likely it just biodegraded into the wound bed. I mentioned earlier that MMPs, right, when they develop an excess, they start to feast off of the body's own collagen. Well, that's why we add collagen to the wound bed, because this becomes that sacrificial substrate. The MMPs eat the dressing instead of the patient's own collagen. And this allows for that wound healing to kickstart again, and we get back on that pathway to healing. Now, one other thing I want to point out here with Puricol, with this dressing, we just need, because it comes in a very thin sheet. When you're placing this in the wound bed, just make sure it's in contact with the tissue. You don't need to stack like let's say you had a really deep wound, you don't need to stack 15 pieces of Puricol on top of one another. And I point that out because we want to be good stewards of cost. And Puricol, you know, can become quite expensive if you start to do that. And it just really needs to be in contact with the tissue. If you need to put a couple of different layers in order to do that because the wound is so deep, that's fine. But you're not going to fill up the entire deficit of the wound bed with the Puricol. Now, your supportive products, the last group said they weren't doing a lot of compression therapy. Not sure if that's the same for you guys on the line, but you do have AccuWrap, which is our 2-layer compression bandage system. What is really unique about AccuWrap are these accuracy indicators that you see down here at the bottom of your screen. So when you open up this box, let's start with that. You're going to find a perforated tab that runs along the edge of this box, and that's actually intended to be torn off and given to your patient. This is instructions for them on how to care for the limb, why they have this product being utilized on them in the first place. Then you're going to find your base layer. So it's the white layer that goes against the patient's skin, does not provide compression. It's just there to protect the area. It has absorbency capabilities in terms of normal perspiration of the limb. But if you have an actual ulcer or an actual wound, make sure you do your wound care, your treatment before you start to apply your compression wrap. So we've done our base layer, and then now we get to your compression layer that has these accuracy indicators printed all along the outside. So make sure that that piece is facing you when you're doing your compression wrap. And if you're not doing compression a lot, this is what I really love about this product, is because sometimes you might walk out of that patient's home and you're like, I don't even know if I did the compression right. It's been so long, I haven't done it in years. AccuWrap's going to let you know, okay, I did this correctly. I know I'm providing therapeutic compression. So when you pull this out, you'll see that the indicator looks like a diamond within this rectangle, okay? The first indicator that you want to see happen as you stretch is that diamond to turn more so into this box within a box. Okay, that tells you, okay, I've achieved full stretch. I'm actually providing the appropriate amount of compression. The second indicator is this line in the middle. So this line in the middle is going to be your indicator in terms of where to do your 50% overlap as you go up the limb. So very unique feature about this product, again, helps you guys as clinicians know that you're doing it correctly. This comes in your standard AccuWrap, which you see up here on the screen. This gives anywhere from 30 to 40 of compression for your patients with a normal ABI. We have AccuWrap Lite that delivers 20 to 30 of compression for those individuals with a compromised ABI. The box or the packaging of the AccuWrap Lite will be green in color instead of this purple. And then we have AccuWrap XL, and that's just more fabric to the roll. So if you had a patient with a really large extremity, a really large limb, and you just needed more fabric to the roll, that's when you would go to XL. Okay. Any questions on the products before we do a couple of case scenarios? I know I'm running a little bit over time, and I apologize about the technical issues, but any questions before we hop into 2 case scenarios? Okay, so I'm going to come back to our guidelines, But here's the first scenario. We go in, this is our first time seeing this patient. We find this wound on the sacrum. Okay, this is what it looks like. This is the tissue that we're dealing with. Depth-wise, it measures 5 centimeters. There's a large amount of serous drainage and peri-wound scarring and maceration. Okay, take that in, guys. I'm going to ask you to be interactive with me here in a second. So remember the features of this wound. I'm going to go back to the guidelines and we're going to walk through how to determine the most appropriate treatment. So I mentioned we're always starting out with wound cleansing and peri-wound protection. So we've done that. Now, who wants to tell me, what are the wound bed characteristics? Is this shallow and dry, shallow and wet, deep and dry, or is it deep and wet? Again, if you don't want to come off mute, that's fine. We can use the chat feature, but someone tell me what we're dealing with here.
It's deep and wet.
Deep and wet. Thank you, Angela. Absolutely correct. So it's deep and wet. Now, based upon the tissue that you guys saw within that wound bed, our first question again is, does this wound need to be debrided? Did you guys see slough or eschar within this wound bed? Slough or eschar? Angela, don't leave me now. You're walking all the way through with me, Angela.
No,
Okay, good. No, it does not. So we know that we can skip the D column. We don't need to use Therahoney. Our next question then is, okay, is it showing signs and symptoms of infection?
I say no.
No, correct. You are right. There were no signs and symptoms of infection. So we know we don't need OptiCell AG. So now we come to moisture balance. Again, this is our first time seeing the patient.
Can
So
I ask you a
we
question
can't,
real quick?
yeah.
Sorry, because I'm dealing with this right now with a patient. So I am using the AG on this patient. Now, would that help prevent infection?
That's a good question. Sometimes, depending on the location of the wound, we do use AG products sort of as surveillance. So like, for
wound.
example, like a diabetic foot ulcer, especially if the patients are ambulatory, you know, it's all, they're walking around and getting dirt and grime in that wound. So sometimes we use AG products as surveillance. Yes. But for this specific one, let's say we're not trying to do that, right? We're not trying to use AG as preventative.
Yeah, got it.
So our next question is moisture balance. Based upon everything we've talked about today and looking at that wound, do you think that this is where we are going to stop and determine our treatment?
Yes.
Yes, yes. Say it with conviction, Angela, because you're correct. This is where we're stopping. The tissue is viable, right? It's healthy. It does not need to be debrided. It does not have any infection issues going on at the moment. And we're not saying it's stalled yet, because this is the first time we're seeing this guy. So we just want to make sure that we're maintaining a moist wound base. So we don't want it too dry. We don't want it too wet. We're going to put OptiCell into the wound bed. We're going to fill the depth with our OptiCell. Now, because this is a wet wound, when we take our OptiCell out of the package, we just stick it into the wound bed the way it comes out, dry, and then the drainage is going to allow that gelling fiber to actually gel. Now, in 2 weeks, if we determine this wound is healable, but every time we go in, you know, despite the use of OptiCell, every time we go in to see this patient, the wound looks exactly the same. That is when you would determine, okay, now we're dealing with a chronic stalled wound. We need something to kickstart this. There's an underlying issue that's going on. And that's when you would move over to this edge column. But if you've determined it's maintenance or it's non-healable, you would just continue on with this OptiCell. Because we know we're really not going to make any progress with that. It's just keeping the wound at bay. All right, I have one more. Angela, feel free, but if someone wants to take the pressure off of Angela, this is our next scenario. So we have a 78-year-old female. We see upon our initial assessment, this wound on her left buttock. So completely necrotic, right? About 90% eschar, 10% slough. Because of that, there's not any measurable depth right now. We see a scant amount of purulent drainage and some peri-wound erythema. So let's go back to those guidelines. And we've cleansed, we've done our peri-wound protection. Who wants to tell me the characteristics? Is it shallow and dry, shallow and wet, deep and dry, or deep and wet?
This is Crescent Globe. I found my mute button that I could actually talk and not have to let Angela do all the answers.
Oh, okay.
So I'm not sure that we can even tell if it's shallow or deep because it's necrotic. But it looked like it was maybe dry.
Dry, yeah. So it's definitely dry. Now, so sometimes when I show the scenario, nurses say, oh, it's deep. It's not deep yet. We know that at some point it's going to be deep once we've done what we need to do with the wound. But right now, because that necrotic tissue's at basically the surface level of the skin, there's not a depth to it. It's shallow based on right now at this current moment. So shallow and dry. So we know we're working in this column right here, right? Or this row rather, sorry. First question is, does it need to be debrided?
Yes.
Absolutely, absolutely. So we know that we're going to use TheraHoney. Again, you can use the gel or the sheet. It's up to you guys, you know, what you prefer. Both of them are going to work to debride that necrotic tissue. But are we done? Do we just slide on over here now and choose our secondary dressing, or is there something else we need to address? Remember, we saw peri-wound erythema and then some purulent drainage. So do we need to do anything other than honey?
Go ahead, Jill.
I said it's got the infection, so you need to do the infection column.
Yes. So again, remember, sometimes we work between these two. Perfect. So we're going to put TheraHoney onto the necrotic tissue, and then we're going to add OptiCell AG. Okay, OptiCell AG is going to address the infection. Because this is a pretty dry wound, we want to moisten that OptiCell AG with some saline or wound cleanser. Now we're done. Now we slide over here. Oops. Now we slide over here to our S column and we choose our secondary dressing. So you can use your Gentac because right now it's pretty dry. More than likely it's going to start to become a little bit more exudative. That's when you might want to transition over to an Optifoam. Now let's say we go in next week and we don't see peri-wound erythema. We don't see purulent drainage. There's still slough and eschar. That's when we revisit DIMES and we just simply take OptiCell AG out of the treatment plan because we don't need to use that anymore. Now we're just addressing the debridement aspect. So we keep honey and then we keep monitoring that wound and we constantly think, okay, am I still using the most appropriate treatment based upon my wound bed characteristics? So really something that we should be thinking about each and every time. I know, you know, being a wound care nurse for many, many years, it's easy to sort of get caught up in, well, this is the order, this is what we're using. And sometimes we need to take a step back and ask ourselves, okay, is this still the most appropriate treatment? And that's why we always say, hey, every time you're in there with the patient, just look at your DIME sheet and ask yourself these questions. It's going to lead you to the right treatment time and time again. So lastly, I just want to go over a couple of the skincare products. that you guys have available to you. The first one is your Essentials No Rinse Spray Cleanser. This is for hair and body cleansing. It's really great when it comes to incontinence cleanup episodes. It's going to help you guys not just remove the incontinence, but also your any sort of barrier creams that you might be utilizing. So you'll notice that with Medline, we try to make everything as intuitive as possible for you guys caring for patients. So our skincare line has color-coded packaging and really a play on words for all of that. So for our cleansing products, green is to clean. So anytime you see a Medline green colored skincare product, you know it's for cleansing. The next one is your clinical zinc oxide paste. So orange is for optimal protection, or orange is for open skin. So this is going to be your barrier product for those individuals who have already developed incontinence-associated dermatitis. They have denudation down there in the perineal buttocks area. This is zinc-based, obviously, so it's going to dry out those open areas and then, seal out wetness from further incontinence episodes. If you need a product that has menthol in it, we have our specialized Protect. Sometimes, patients do complain of a lot of irritation, pain, itchiness from the incontinence-associated dermatitis, and the menthol will help relieve some of that. So if you do come across those instances, we do have a product available for you in that realm as well. Most important thing about barrier products in general, whether it be ours or someone else's, is we want to make sure we're applying a very thin layer. When we start to cake these products on too thick, it becomes extremely hard to remove. And so what we find ourselves doing, just trying to remove these products, is rubbing the raw skin, or rubbing the skin raw, and we're actually doing the opposite of what we're trying to achieve. So thin layer, we often like to say, hey guys, act like you're frosting toast. We're not buttering, act like you were buttering toast, not frosting a cake when you guys are applying these products to the perineum and buttocks area. Very important to educate your nursing aides on this as well. And then lastly, we have your antifungals. So red is for rash. We have a powder, and then we have an ointment. So your powder is going to be utilized in areas that are already trapping moisture. So breast folds, abdominal folds, in between the toes. We don't want to don or put more moisture with an ointment in those areas. Both your ointment and your powder is a 2% miconazole. Okay, they need to be applied at least for 14 days, twice daily. Okay, so twice a day application for at least 14 days. I can't stress that enough, because if we start applying this to, what's today, Wednesday, and I go back into the patient's home next Monday and I'm like, oh, great, the fungal infection's gone. We don't stop, okay? It needs to be a full 14-day regimen. Because if we don't completely suppress those fungal spores, we're giving them an opportunity to rear their ugly head again. Very similar to when we go to the doctor and we get a 10-day course of antibiotics, we're supposed to finish the full 10-day course. Same rule of thumb applies to your antifungals. So at day 14, if you see that it's resolved, great, discontinue it. At day 14, if it's still there, you can go up to 21 days and then all the way out to 28 days. At the 28-day mark, if you have noticed that the fungal rash has not improved, there's a good chance we may have gotten the etiology wrong, and that's our opportunity to go back to the provider and see what they want to do going forward. They might revisit the etiology, they might tell you to continue with the antifungal, but we need to be having that conversation. So you also have the ointment, same ingredient, 2% miconazole nitrate, same thing, twice a day for 14 to 28 days. Now, this can be used on areas such as the back, the legs, arms, anywhere on the body that's developed a fungal rash. I'm going to say something right now that sounds like I'm contradicting myself from the last slide. I said use the powder on areas that are trapping moisture. The ointment you want to use in the perineal area. And here's why. This is formulated with a product, or an ingredient rather, called CMC. And CMC sticks to wet or damp skin. And normally when we see fungal infections occur in the perineal area, it's because of or in combination with incontinence. So this is going to be able to adhere to that moisture and seal out wetness from further incontinence episodes while continuing to treat that fungal infection. So the ointment you do want to use in the perineum, the powder is for those other areas that trap moisture. And I hope that makes sense. I hope I didn't confuse you guys with that. But that's the gist of your skincare formulary products. And then last but not least, we talked about that skin health hotline. This is Gail. This is the board certified nurse that you would be speaking to on the other end of that hotline if you were to call. Again, available to you Monday through Friday, 8 to 5 Central, 9 to 6 Eastern. So what is that, our time? 7 to 4. So just, keep this in mind. Know that it's a resource for you guys. If you have any questions, call, and we will be able to help you guys to as much as, we're able to within our scope of practice. Any questions? Okay, guys. Well, I appreciate you joining. I hope that you found this to be beneficial. If there's anything that, comes up, any questions that you have, I'm actually going to put my email here in this chat box. If there's anything you need, please, don't hesitate to reach out to me. I'd be happy to help you with any clinical questions that you might have. And then, of course, you guys have Greg. Here's your local sales specialist. But again, thank you for joining. Apologize for all the technical issues. I hope you guys have a great rest of your day and a great rest of your week too. We're almost to Friday. Thank you so much.
Thanks, Melissa. Appreciate you.
You're welcome.